Advisor of BSCC 2025 for entrusting me with the opening talk of mine, Choosing Wisely Bangladesh, Top 10 Practices That Should Be Avoided in Cancer Care, the result of the first phase. I'm Dr. Nowshin Taslima Hossain, working as Junior Consultant of Radiation Oncology Department in Hossain Mission Cancer and General Hospital. I will be here for the next few minutes, and I have no disclosure of interest. Choosing Wisely began in the United States in 2012. Formal lists have been published by ASCO in the US in 2014, then in Canada in 2015, then in Australia, India, Africa, and Philippines. In pace with Global Choosing Campaign, we started Choosing Wisely initiative in Bangladesh 2025. We know we have a lot of shortage of resources, but we misuse our resources most. Breast cancer and cervical cancer are the most two common cancers in Bangladesh. But every fine morning, we find a lot of patients of cervical cancer doing unnecessary hysterectomy in stage 3 and 4. In breast cancer patients, we found that surgery has been done without knowing the ERPR status. Sometimes chemotherapy has been given, even without knowing the ERPR and HER2 status. So, the overview of Choosing Wisely campaign is to identify and reduce the low value or harmful practices intervention in Bangladesh, a country with limited healthcare resources. We know cancer cases are increasing day by day, but we have insufficient resources, including chemotherapy centers and radiotherapy machines. So, the campaign seeks to prioritize cancer treatment for those with the most urgent needs. Methodology starts with the literature review. We review the global Choosing Wisely recommendations which have evidence of low value, and we identify those practices that are relevant to Bangladesh context. Then we generated a preliminary list of 29 low value or harmful practices, and also we took expert opinion from the radiation oncology, medicine oncology, surgical oncology, gynae oncology, and palliative care team. This is a result of the first phase. We know palliative care is neglected in our cancer care nowadays. Actually, it's a very sad thing. So we advise don't delay the palliative care for patients with serious illness who has physical, psychological, social, or spiritual distress. We advise don't use systemic treatment with patients who have low performance status of 3 or 4. Regarding investigation, we advise don't perform PET-CT scan to detect recurrence in early stage cancer patients and also for cancer screening in healthy individuals. Don't forget to discuss the value of biomarker testing in specific solid tumors where targeted treatments have proven benefit. We also advise don't treat metastatic cancer patients in intensive care unit as they have no added value. Don't deliver care in a high-cost settings in patient cancer center that could be delivered as easily in a lower-cost setting. And also, don't start treatment without confirming the diagnosis and defining the extent of the disease with the patient. Don't advise unnecessary blood transfusion. Don't hide the prognosis of the disease from the patient. We advise don't use surgery without starting systemic treatment or radiation therapy where they are applicable. In case of breast cancer patients, please don't do surgery without confirming the histopathological diagnosis and without knowing the ERPR and HER2 status. Do surgery with adequate cancer oncology training and adherence to standard surgical principles. In case of gastric surgery, we advise don't do gastrectomy only with seeing the histopathology report and the endoscopy report. We have to do the surgical staging workup. BCS should not be done without frozen section facility or marker placement. In case of rectal or colon cancer patient, try to do the whole staging workup only aside by proctoscopy or sigmoidoscopy. And in case of hysterectomy, please, in case of cervical cancer patient, please don't do unnecessary hysterectomy, unplanned hysterectomy without proper evaluation of postmenopausal bleeding. In case of radiotherapy, we advise please try to give conditional radiotherapy technique in case of palliative settings. If the life expectancy is less than 3 months, try to cope with single fraction of palliative radiation in case of uncomplicated bone metastasis. In case of breast cancer irradiation, in early stage, if adjuvant endocrine therapy is planned and ages more than 70 and 65 years, radiotherapy can be omitted. Avoid use of prolonged fractionation of radiotherapy where hyperfractionation proven the similar benefit. Don't continue curative intent radiotherapy on a machine with unresolved safety and quality assurance issue. Avoid the use of ground-side constimulating factor if the risk of developing febrile neutropenia is less than 10%. Don't use combination cytotoxic chemotherapy when treating an individual for metastatic breast cancer unless it needs a rapid response. In absence of EGFR mutation in non-small cell lung cancer, the use of TKI is not recommended. Before starting treatment of sarcoma and prostate patient, try to take decision in a MDT, that is multidisciplinary team, including clinical, surgical, medical, radiation oncologists, as well as specialists such as pathologists, radiologists, psychiatrists, nutritionists, and physiotherapists. From this 29 recommendation, we will finally recommend 10 recommendations with the help of whole oncology community through the survey list. Choosing wisely Bangladesh, when it detects a 10 low-value cancer intervention, then we will try to implement this throughout the whole Bangladesh. The success of this initiative will depend on its implementation across the low and middle income countries where it can enhance the cost-effective cancer care delivery. This campaign presents a critical step in transforming the cancer care policies, ensuring that resources are prioritized for the most urgent cases. Future efforts will focus on integrating this recommendation into the National Cancer Care Protocol to improve patient outcomes despite resource limitation. Thank you all.
Thank you. Just wait for the technical.